Welcome to the NCAI Policy Research Center monthly webinar series. Hello, I'm Dr. Yvette Rubidoux, and I'm the director of the Policy Research Center at the National Congress of American Indians. Welcome to our monthly webinar series. Today, we will focus on the opioid epidemic and hear what the Indian Health Service is doing to address this growing problem. Last month, we had a very successful webinar featuring our own Amber Ebarb discussing geospatial data considerations for tribes. If you missed our webinar in February, the recording is available on our NCAI YouTube page or on our website, www.ncai.org/PRC under webinars. We are so glad you joined us today and encourage you to watch for our monthly webinars on the fourth Thursday of the month that will focus on how data informs policy and will feature a variety of topics and various guest speakers from time to time. So here's an overview of today's agenda. I just provided the welcome. And our speaker is Captain Cynthia Gunderson, PharmD, and Vice Chair of the Indian Health Service Hope Committee, which stands for the IHS Heroin, Opioids, and Pain Efforts Committee. And we will reserve time for questions at the end. But before we get started, however, I'm going to review a few housekeeping items and let you know how you can participate in today's webinar event. So this is a depiction of the GoToWebinar attendee interface, and it is made up of two parts. The viewer window on the left, which displays the presentations, and the control panel on the right. I'll quickly navigate how to use the control panel so you can readily participate in today's web event. By clicking the orange arrow, you can open and close your control panel. And here's where you will find all of the information about your audio connection. We recommend dialing in by phone rather than the computer, as it tends to limit feedback. To dial in, you will find the number and access code here, along with your unique audio PIN. As you can see, all attendees are currently muted in listen-only mode. At the end of the presentation, we will open for questions and answers. At this time, please submit your questions via the question pane. And as a reminder, today's webinar is being recorded. After the event, you will receive an email with a link to a short evaluation, as well as the recording, which will also be available on our NCAI YouTube page and our Policy Research Center website. And now we'll begin our presentation. I just need to switch the slides. All right, so today I'm happy to introduce Captain Cynthia Gunderson, PharmD, who is the Acting Red Lake Hospital Chief of Operations and Acting Director of Revenue Enhancement for the Bemidji area. And she is speaking today in her capacity as the Vice Chair of the Indian Health Service, or IHS, Heroin, Opioids, and Pain Efforts Committee. Thank you, Captain Gunderson.
Thank you for that introduction, and I look forward to speaking with you today and having a dialogue on and continued participation as we address the opioid epidemic in our tribal communities. As Dr. Rubidoux said, we are the IHS National Committee on Heroin, Opioids, and Pain Efforts. So without further ado, we'll get started here. Next slide. Next slide, please. Okay, the mission of the IHS is to promote the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. The Hope Committee desires to do this in consultation with the tribes. We'll look a little bit at the data that's on the slide there in front of you. This data was released by the CDC in October of 2017 and reflects American Indian Alaska Native overdose rates. As you can see, American Indians and Alaska Natives were reflective of the largest percent change in mortality between 1995 and 2015, at a 519% increase among racial and ethnic groups in the U.S. This data is alarming. We'll talk a little bit about the IHS response to providing better access to the IHS RPMS data later on in the presentation, but this just gives us a pictorial representation of the extent of the problem in our tribal communities. Next slide, please. So what is IHS doing to address the opioid overdose epidemic in our communities? So the IHS started the National Committee on Heroin, Opioids, and Pain Efforts, officially chartered in March of 2017. This work was born out of the efforts of the Prescription Drug Abuse Work Group that was started in 2012. The membership of this work group includes dedicated practitioners, generally representative of the field, and includes physicians, pharmacists, behavioral health providers, nursing consultation, and epidemiologists. We recently added representation for physical therapy as well as for our practitioners and pediatricians that serve in our IHS hospital location. The goals of the IHS Hope Committee are to promote appropriate and effective pain management, reduce overdose deaths from heroin and prescription opioid misuse, and improve access to culturally appropriate treatment. Next slide, please. Next slide, please.
Captain Gunderson, we're seeing the slides. I think you might be having a delay, so we'll keep going.
Okay, very good. So I'll just say next slide and let me know if there's a problem with the transition. So the IHS Hope Committee desires to make impacts within the field through various policy efforts. I'd like to overview two of our current policies. The Indian Health Manual Part 3, Chapter 30th, the Chronic Non-Cancer Pain Management chapter, was originally published in June of 2014. This policy provides best practice guidelines surrounding the management of chronic non-cancer pain. The policy was recently updated, and we're pleased to release notice that that's been updated on the website since February of 2018. The policy revisions include an alignment with the CDC guideline for chronic opioid prescribing practices, as well as best and promising practices surrounding patient assessments, functional status assessments, and risk-benefit ratios. The IHS Part 3, Chapter 32 is our groundbreaking policy surrounding participation with state prescription drug monitoring programs. This chapter was originally published in June of 2016, and it establishes formally the requirement for IHS federal prescribers to register with state prescription drug monitoring programs, as well as to request reports for new patients that are seeking to establish care with providers, as well as when prescribing opiates for acute pain for greater than 7 days of treatment, as well as ongoing for management of chronic pain. This policy also establishes the requirement for IHS pharmacies to report dispensing data and conduct PDMP queries prior to dispensing outside prescriptions for opioids. We have two pending policies that are in the process of approval. The first of which surrounds expanding access to naloxone for first responders. We'll talk a little bit about our naloxone efforts later on in the presentation, but this policy really seeks to increase access to naloxone for first responders in tribal communities. And our second policy working its way through the approvals channel is the Internet Eligible Controlled Substance Provider designation. This policy seeks to expand access to medication-assisted treatment in tribal communities that are using telehealth services. Next slide, please. So the IHS Hope Committee maintains clinician supports, the first of which being a series of websites. We actively maintain two very informative websites, the first of which is our pain management. There's a link to that website at the top, as well as our opioid dependence management website. So as you can infer, the pain management website includes best and promising practices surrounding clinician chronic pain management. And our opioid dependence management includes resources for clinicians and tribal communities surrounding access to naloxone, access to medication-assisted treatment, as well as resources for our management of perinatal substance use. We are in the process of a major overhaul to our pain management website surrounding drug disposal, responsible drug disposal, as well as dental acute pain guidelines. Next slide, please. Additional clinician supports available to your practitioners practicing within IHS include access to our IHS Telehealth Behavioral Health Center of Excellence. We have established a tele-echo call that is in a weekly video conference format, and it allows frontline clinicians to consult with experts in pain management, addictions, and behavioral health. This rotational echo program is rotating on the noon hour for each time zone, so it allows our clinicians to participate in these consultative activities without disrupting their clinic schedule. Next slide, please. IHS is committed to the training of our controlled substance prescribers. We have released the Essential Training on Pain and Addictions, and is a web-based 5-hour continuing education course that was released originally in January of 2015. This course was created in partnership with the University of New Mexico, and it's an IHS-specific course that goes over fundamentals and best practices of safe opioid prescribing. This course is now available as a web-based recorded training, which allows on-demand access for our IHS practitioners. It's also available to the general community if you wish to take this training. We've supported the requirement of this training through the Special General Memorandum reflected on your screen, and this establishes a mandatory training requirement for federal prescribers of controlled substance medications, spending greater than 50% of their time in service to the Indian Health Service. All of our IHS federal prescribers are required to complete this within the first 6 months of employment and complete a refresher training after 3 years. As of the end of 2016, 96% of our active prescribers have completed this training. The IHS refresher training on pain and addictions was released in January of 2018. As I mentioned, we require our prescribers to redo the refresher training every 3 years. So our first cohort was due for refresher training in February of this year. So all of this training is available via our website. Next slide, please. So harm reduction is a pillar of our IHS response to stemming the opioid epidemic. As you are probably all aware, in December of 2015, IHS established a memorandum of understanding with the Bureau of Indian Affairs to provide naloxone to trained first responders serving in tribal communities in conjunction with their BIA roles. This was a MOU required the training component to effectively deliver the naloxone and respond to opioid overdoses, as well as required IHS federal pharmacies to furnish the naloxone to BIA. This has been a very, very promising MOU and partnership with the BIA. Our pharmacists have developed a training curriculum as well as a naloxone toolkit, which is available for download on our ODM website. I've also listed the link there for you as well. This toolkit includes a variety of resources, formatted forms, sample MOUs to use in your tribal community if you are a tribal law enforcement program, as well as a series of training videos. So we have developed a 19-minute training video that specifically goes over the 3 available formulations of Narcan or naloxone, as well as the requirements to respond to overdoses. And finally, we've captured a video of an officer testimony following the first reversal by a BIA officer. Next slide, please. The other arm of our harm reduction program is our naloxone co-prescribing program. We have hosted a grand rounds that was a combination presentation with an IHS primary care provider as well as a pharmacist that went over the best practices surrounding and providing that naloxone as a take-home medication for those patients that may be at risk for opioid overdose. We've also developed a pharmacy-based model collaborative practice agreement that is available also on our ODM website that will allow you to download and customize this if you wish to dispense pharmacy kind of as an over-the-counter item out of your pharmacy program. We've also captured a list of our procurement from our IHS federal facilities in the graph at the bottom of the slide. And that's our purchasing data and not our dispensing data. So those are the naloxone doses that have been purchased by our federal facilities. Next slide, please. All right, shifting gears to medication-assisted treatment. So we've talked a little bit about our clinician supports as well as our crisis response services, and we'll talk a little bit about our recovery efforts. So we know that medication-assisted treatment for addiction includes the use of medication, counseling, and support systems. The treatment that includes medication is oftentimes the best choice for opioid addiction. However, treatment regimens for patients should be patient-specific and based upon the needs of that patient. Medication-assisted treatment allows a person to be free to reduce the thinking and cravings for the drug. These changes can give a person a chance to focus on lifestyle changes that lead back to healthy living. Next slide, please. So specifically within IHS, we've developed several responses to expand treatment capacity within our IHS communities. So we are trying to expand our utilization of office-based opioid treatment training. So we've partnered with the American Osteopathic Academy of Addiction Medicine in SAMHSA to allow access to the PCSS MAT modules that provides that 8 hours needed to obtain the data waiver to prescribe buprenorphine in an office-based setting. So this is a half and half training, and it includes four hours of webinar training, as well as an online study and an exam, which is 5 modules. We've found kind of various interest in participation of our prescribers on this online tutorial. So we actually developed a live training that has had some promising attendance in the last year. So we're calling this our Pain Skills Intensive Training. This includes a 1-day training on myofascial pain management techniques, as well as on the second day, the data waiver training. This was previously hosted in the Bemidji, Albuquerque, and Portland areas, and IHS has the plans to offer this curriculum in the fall of 2018 in Oklahoma City. All right, next slide, please. So a look at what's coming on the horizon. Our work plan for the 2017-2018 year included a real desire to increase our listening sessions with our tribal communities to ensure the relevance of the HOPE committee work to the field. We have to date hosted listening sessions at the Combined Councils, the Direct Service Tribes meeting. We've done 2 with USET, as well as a larger one with the Behavioral Health Conference down in Tulsa, Oklahoma, as well as your very own meeting in October of this past year. Our plans also include expansion of that myofascial pain training that we've talked about, as well as expanding availability of controlled substance disposal services within all of our federal IHS facility. This would allow your pharmacies it would facilitate your pharmacies to develop these on-site disposal mechanisms versus participation in the DEA take-back days. So it just would give your community members an option to readily dispose of unwanted or unused controlled substance medications. We are actively developing a dental acute pain prescribing guideline in conjunction with our Division of Oral Health. This guideline goes over the various procedures that would be in a dental patient, as well as best practices surrounding prescribing pain relief for acute pain management in this population. We're creating a YouTube MAT video series for tribal and local leadership, which will include an overview of what is an opioid, as well as successful MAT strategies to kind of reduce stigma surrounding MAT addiction and recovery within our tribal communities. We're also, as part of our harm reduction program, we're researching the components of safe syringe exchange programs. So this is to directly impact our hepatitis C and HIV rates and to help reduce the spread of sexually transmitted infections, as well as bloodborne pathogens within our population. And again, this would have to be in collaboration with local tribal programs. So it's just really to create the toolkits and mechanisms to roll these programs forward. Next slide, please. All right. Big focus area for 2018, 2019 is to really develop and share best and promising practices surrounding neonatal opioid withdrawal syndromes within our populations. This really focuses on the mother-baby dyad. So we want to treat both pregnant and parenting populations, as well as to improve the management of our infants born dependent on opioids. Components of this include early intervention, early screening techniques, referral to medication-assisted treatment programs, and awareness of trauma-informed care to really intervene on and make an impact on this perinatal substance use that's in our communities. We want to identify mechanisms to increase access to prenatal care services. So we're sensitive to the fact that increased screening interventions may delay prenatal care. So it's important to create programs, guidelines, and resources that encourage access to prenatal care services in a supportive environment. And finally, our metrics work group has been hard at work to establish a opioid data mart available via our behavioral health data mart series that allows tribal communities and IHS sites to look at their local prescriber level data, as well as to make a comparison with area and regional data to look at real analysis and tools to identify trends that may impact our ability to deliver interventions. This is a three-phase project. Our first phase is currently in the testing, development, and implementation phase. And it includes a look at percentage of opioid prescriptions per 100 patients, concurrent opioid prescription with a benzodiazepine that may put a patient at risk for opioid overdose, the number of naloxone units dispensed, as well as the number of opioid use disorder diagnoses captured within the IHS electronic health record. The second phase of the data extract will really drill down to prescriber level data, where prescribers will be able to look at their patient population and how their average morphine milligram equivalents compare to practitioners of similar practice settings, patient populations, et cetera. So we really want to make sure that we're doing the opioid prescribing effectively and responsibly. So that's an overview of what the IHS HOPE Committee has been working on, as well as our updates since we last spoke in October. The last slide includes email contacts, so you can reach out to any of the officers of our committee, ask questions, recommend interventions, next steps, things that you would like the HOPE Committee to reflect on or create, as well as the names of our work group leads. Feel free to reach out to us at any time. Thank you for the opportunity to speak with you today, and I'd really like to take your questions. And
great. All right, thank you so much. That was a great presentation, and looks like lots of things are going on. So for the audience, we'll now take time to answer some of your questions that you've submitted on the questions pane. You can keep submitting them, and we'll try to get to as many of them as possible before the end of the webinar. Your questions won't show up if you're bashful. They'll show up for us, but not for everybody else. So please feel free to submit questions. The first question is, how much of these resources are available to tribal and IHS programs?
That is an excellent question. Our websites are open source, so every resource that we have developed and that has been approved and hosted within our IHS Hope Committee is available on those two websites. We tried to make we revised the websites probably about 6 months ago to make this more user-friendly so that you're able to navigate these resources in a way that makes sense. So the headers of the information are very user-friendly. The Opioid Dependence Management site, that ODM site, so if you think of anything with treatment, recovery, intervention, it's going to be on that ODM site. The naloxone toolkits are very comprehensive and can be downloaded, and in most cases, those are Word documents that you can easily customize and adapt in your tribal communities. The pain management website, anything that has to do with chronic pain is going to be on that website, and that is where the dental acute pain prescribing guideline will also reside.
Thank you. I appreciate all of that being available. We've had tribal clinics come to us and say we'd like to learn more about what we can do locally. So it sounds like there's some great resources here. The next question is, on the metrics slide, you indicate you will assess the impact of interventions. Is this underway, or what is the plan for this? So the plan for this, we have a metrics work group that is functioning almost as a steering committee. So the impact of our interventions will be established in that phase 3 project. We're really looking to the collaboration with our national partners within HHS. They have identified some potential metrics that the Hope Committee will be evaluating in consultation with the tribes in that phase 3 project. Great, thank you. The next question is for me. The opioid epidemic is a huge thing nationally, and a lot of people are taking actions. And I just got an email from the state where I'm licensed where there were a number of new requirements. How are you handling as the Indian Health Service your requirements for your providers when now it looks like states might be implementing additional requirements?
That's an excellent question. So we're very cognizant and trying to keep up on the requirements by the state licensure boards. Where possible, we'd like to interface with the states to say, well, IHS has this essential training on pain and addictions. Will this course cover their licensure requirements for that practitioner practicing within that state? We're ongoing conversations with the DEA surrounding the number of hours that they're looking at requiring, and will the IHS essential training cover those requirements? So it's really working within our state programs and with our relationships with our providers to ensure that these credits that are transferable between IHS as well as the states in which our prescribers are licensed.
Great, thank you.
May I ask what state you're licensed in, just so we can make sure that we're
I'm licensed
capturing
in
those
Arizona.
Arizona, okay. Yes, very good. Thank you.
The next question is, there's lots of talk in the budget talks about more money for opioids, addressing the opioid epidemic. And what is IHS going to do if it gets more money for the opioid epidemic? Will there be tribal consultation?
That's an excellent question. At the Senate Committee of Indian Affairs testimony last Wednesday, this very topic was brought up. As we know, HHS is proposing $150 million to go toward the opioid epidemic, And IHS expressed at that testimony that we have heard from our tribes that the grants process is not always the best way to get that money into the tribal communities. So that was expressed at the hearing, and is expressed to HHS oftentimes, as well as to SAMHSA, that we need to look at ways beyond state block grant funding and beyond competitive grant processes to ensure that these funds flow to tribal communities. So we've heard that throughout our listening sessions and are very sensitive to that.
Thank you. Again, a reminder to the attendees, you can submit your questions on the questions pane, and we'll answer as many of them as possible before the end of the webinar. The next question is, what types of opioids are you seeing as being big problems in tribal communities right now?
Types of opioids right now. Okay, so as far as emerging drug trends go, we're really seeing a spike in the fentanyl analogs, or those synthetic opioids. So you think fentanyl, carfentanil. So we're really starting to hear reports from tribal communities that these synthetics are invading. As we know, in the practice site where I practice up in Red Lake, we have confirmed this via our labs, and it's requiring repeat doses of naloxone to reverse these opioid overdoses with the synthetics. So just be mindful in your tribal communities of the opioid overdose trends and drugs of abuse, in partnership with your law enforcement programs, in partnership with the BIA and DEA, access to that toxicology services to ensure that you have equipped your first responder staff with multiple doses of naloxone, as well as trained your community to seek aftercare following an overdose, just to ensure that the overdose is completely reversed and the patient doesn't relapse into that overdosed state.
Thank you.
We're also seeing and hearing reports in our tribal communities that it's transitioning. The question was about opioids, but we're also hearing reports of methamphetamine as well. So just want to include that.
Thank you. The next question is about if a tribe needs help in measuring data around what the opioid epidemic might look like in their own community, what suggestions do you have for them to, because there could be very different substances, like you just mentioned. It could be fentanyl, it could be prescription drugs, it could be methamphetamine, of course there's alcohol, other street drugs. What are some things that tribes can do to measure their local, figure out the picture of their local epidemic?
That is a great question. So tribes are very good at identifying their local resources and partners within their communities. So when I think of the resources and partners available, obviously the healthcare program within your community. Oftentimes, if you have access to ER relationships if you have access to an emergency room, an IHS emergency department within your tribal healthcare facility, oftentimes we'll have data of what kind of illicit drug trends that we're seeing, partnerships within law enforcement, and like we mentioned that the toxicology information, partnerships with the tribal epidemiological centers, as well as getting an idea of what the state epicenters are reporting as emerging trends. We're able to do some predictive analysis of what those illicit substances are that we're treating within our communities.
That's great, thank you. Another question. On slide 3, the drug-related death rates, you provided 2 graphs. Where can we access those data?
And that's a great question. I do apologize for the title on those graphs. That is the MMWR, the morbidity, CDC morbidity, mortality report from October 2017 with references to national vital statistics. I can send the link to that report.
Great, thank you. It's now last call for questions on the question pane. You just type the question and hit the button. After hearing the questions, Captain Gunderson, is there anything else you'd like to share with the audience?
With the emerging drug trends, is that what you're seeing in your communities as well, is the synthetics?
The interesting thing is NCAI hears a lot from tribes about the different types of challenges they're seeing locally, and just would be interesting to have more local data on the patterns of the different types of drugs. We have another question. It says, is HOPE able to provide assistance to urban IHS areas that are not on reservations, or programs that receive IHS funds but not IHS facilities? I guess this is like the urban Indian health programs.
The urban programs. It would depend on the level of support requested. If it's policy level support or training, we have assisted with those requests. If it's something like providing naloxone, that's a little more challenging to do. So it just would, I guess it would depend on what level of support is needed.
Great, thank you.
Is there something in mind? Are they indicating anything in the chat box?
No, that was just the question.
Okay.
We'll see if they clarify. Go in the chat box or the question pane and see if we answered your question. There's two more questions. The first is, what is one of the greatest messages that we can send to our Native youth in regards to this opioid epidemic?
In my perception of the greatest messages for our youth, I would have to say that culture is prevention. We've heard that in our listening sessions, that culture is not only treatment, but it's also prevention. So get engaged with your culture within your communities. And also would like to say that treatment is effective. So there is hope. If you have an opioid use disorder diagnosis, or if you have a family member or loved one, that there is help.
That's really great. And the last question is, who have you heard in terms of the tribal facilities or tribes who are doing really great things around addressing the opioid epidemic? Can you name a few tribes that might be examples? Or
of best practices?
Yes.
Okay, so we have some really great tribal best practices. One of my favorites, and I know I shouldn't pick favorites, but I'm a pharmacist, but I'm also a mom. So any of our moms programs that are providing inpatient residential treatment or outpatient residential treatment, I really hats off to those programs. My favorite happens to be in White Earth, which is actually in Minnesota, the state where I practice. They have an amazing MAT program where they're holistically addressing addiction and recovery efforts with their pregnant and parenting families on the White Earth Reservation. As far as promising federal models, my favorite there is actually the Gallup Indian Medical Center. They've been able to increase their data wage prescribers tremendously in the past, I want to say 18 months that they've been actively working on that. So as far as a federal model, they are a promising practice.
Great, thank you. Someone just also mentioned that Fort Gamble Sklallam has a great program, the THOR program.
THOR?
The last question is a clarification on the urban one. It says, They were wondering if you could provide assistance, and they said it would be in the form of a training in a conference setting for the urban area. Does IHS do that?
It would depend on, I can't commit IHS resources to that, but I can take that request. The way that we've done this in the past is to identify what resources are available on our HOPE committee and identify HOPE committee membership in that area that could provide that technical assistance. So I'm thinking specifically with naloxone mobilization and training events within the Bemidji area, within the Phoenix area, Oklahoma area. We've provided support to tribal and urban programs in those areas. So if you wanted to reach out with specifics to me, just via email, if you're comfortable with that, I can provide you a definitive answer.
Great. And I just put the slide back up with all of the contacts related to the HOPE committee and all the different topics for the audience. These will be on their slides, which is on the handout that's available for the webinar as well. So that'll be our last question. I'd first like to thank our speaker, Captain Gunderson, for her very informative update and willingness to join us today. She's in the middle of a meeting and is doing her best to take time out for this webinar, and it's so important to us because it was at the request of our member tribes. We'd also like to thank all of the people who joined us today. In particular, I'd like to thank Maria Gibbons, who's the policy analyst at NCAI, for her help today with the webinar. And don't forget to complete the feedback form that you will receive in the follow-up email after this webinar. And this webinar will be made available as a recording soon on our YouTube channel that you will be able to access from our website. And once that is available, please feel free to send the link to the webinar recording to any of your colleagues who may be interested. And the last slide, just a couple of announcements before we leave today. Mark your calendars for this NCAI Policy Research Center monthly webinar series. It's always on the fourth Thursday of the month, and watch for announcements for the next topic. And save the date for our 13th Annual Tribal Leader Scholar Forum to be held during the NCAI 2018 Mid-Year Conference in Kansas City, Missouri on Tuesday, June 5th, 2018. We will be featuring several sessions where researchers will be presenting and interacting with tribal leaders, and we also will be planning a pre-conference session on Sunday, June 3rd. If you happen to be someone who submitted a proposal to present, don't worry, we plan to send our speaker invitations out by the end of the month, and we hope to see you all there. You can find the registration information for the NCAI Mid-Year Conference on the NCAI website at www.ncai.org. And also watch for a new NCAI webinar series focusing on other topics related to the opioid epidemic, and that should be starting in April. So again, thank you to our speaker, and thanks to everybody who joined us today. We hope you have a great rest of the day. Goodbye.